Welcome. My name is Dr. Thomas O'Connor, the Metabolic Doc, and today we have a very, very important video we're presenting with my colleague, Dr. Brett Nowlan, who is a cardiologist. And the title today is Testosterone Replacement, Can It Lead to Heart Disease? So in the literature, going way back to 2013, 2014, 2 studies, and then in the end, the federal government, the FDA, came up with a new in-box warning on testosterone products, indicating that testosterone can cause heart attack, stroke, and death. Since that time period, it's been just amazing what's happened, and primary care doctors, endocrinologists, urologists, experts in taking care of men on testosterone have felt very uncomfortable, in essence, that testosterone can cause heart disease. So today, we're going to go back to the basics. There is essentially 2 great studies that we're going to review. Dr. Nowlan's going to help us do this today because he's a board-certified cardiologist, and assess, have these studies led to a legitimate increase in risk for coronary disease? Right. The first study is the Jama Study in 2013. We'll refer to that as the Jama Study. The next study is the PLOS study in 2014. And then in the end, we're going to tie in and wrap up in the Mayo Clinic proceedings of this year, January 2018, their analysis. Mm-hmm. So let's get back to the science. The initial study was the Jama Study.
Right.
Tell us about this study.
Got it. All right, and thanks for having me here today. This is obviously a very important topic, something that a lot of men care about a lot. So to make some sort of 1,000-yard overview comments, I think a lot of times when clinical information gets given to the public, it gets given in sound bites, and it gets distilled down to make it something easy to read or attention grabbing, and a lot of the details gets lost. And this is sometimes where people can have the idea that something is dangerous or safe when it really isn't. And I think these 2 trials that you're referring to are great examples where the details are really, really important. Mm-hmm. Because I do not think, and certainly I'm not the only one, there are a lot of people that do not think that the data here was strong or it was good or actually showed something that was of real, genuine concern. So if you look at the Jama study, first of all, so this was a retrospective review. So this was not, our sort of gold standard trials, if you like, are taking 2 groups of patients and you follow them what's called prospectively. So, you give one group a drug or an intervention, the other group you're giving them placebo. No one knows what they're getting. You as the researcher don't know what people are getting, and then you look at outcomes. That's sort of the gold standard, and mm-hmm. neither of these were that. And what the Jama study was doing was looking back at data of men in the VA, and it was looking at men who had undergone an angiogram, so looking at the coronary arteries, and then men who had low testosterone, some of which had their testosterone replaced, mm-hmm. and some who didn't. Mm-hmm. And then they were looking at events going forward. Mm-hmm. But again, all in a retrospective fashion. So just trawling back, this was not a randomized trial.
And that's the key word, retrospective right. versus a prospective right. trial.
Right. Now, again, the devil's in the details here. When you look at what was published as the outcome, it looked like there were more events in the men receiving testosterone. And that's what grabbed attention, mm-hmm. frankly, from both the public and the FDA. However, there's been a lot of criticism about that data and what actually happened to it before they came mm-hmm. to that conclusion. So the actual raw data, before they did any kind of statistical analysis, actually showed a lower event rate in the testosterone group. And we're not talking a subtle amount, we're talking 50% wow. less. So a very big difference there. And then, statistical analyses were applied. You're sort of trying to correct for this factor and that factor, and sort of after all that manipulation of the data, the published outcome was, oh, shucks, there were higher events in the testosterone group. So clearly a lot happened there in the analysis.
That's incredible, and
Right.
that's amazing. Yeah.
Right. So that's why the details are so important. A lot of people who then looked at that paper and sort of drilled down into those numbers actually raised a fuss. They said, look, there's something off about this data. The article was actually adjusted, it was reanalyzed, and it was republished, and on that republication there was a 50% less event rate quoted. Even then, some people say even that republished data really does not look terribly strong, and maybe that trial should be retracted. That's how strong some people feel about this trial. So, as I said, I think if you just look at that overall as a trial, does that show that testosterone replacement therapy leads to more events? I think one is hard-pressed to say that that's good data.
True.
Let's put it that way. The other trial that you referenced, the PLOS data, so this was a trial, again, retrospective, so you're not actually doing anything in a blinded fashion to people. And this was looking at groups of people and just looking to see whether their prescription records demonstrated that they had been prescribed testosterone, even just once. So that doesn't say they filled it or took it on a long period of time. Did not mention anything about their levels of testosterone, whether they were measured, whether they achieved appropriate levels.
Amazing.
So you can appreciate there's a lot of data missing there to know what the significance is. And all that they did was then compared events pre and events post that single prescription. And they divided up into groups. Have you ever had a prescription for testosterone, or have you not? So there's no way of knowing this from the data, but another way you could look at that data is there were more events in people that probably had low testosterone, because someone had reached the conclusion that they needed a prescription for testosterone. So
there's other associations with men that are sick.
Absolutely.
And it's causality, right? And there are other relationships. A man who has low T, who has diabetes, which we know organically, apart from the steroid using group, that's a major etiology that I see. And therefore, forget testosterone, if you have diabetes, you're at risk.
Absolutely
for
true.
Coronary disease.
So this is why the details about these kinds of data and what these data is supposed to be. They're supposed to be hypothesis generating in order to go on and do clinical trials. That is what these sorts of things are intended to be. I'm not saying these sorts of things are worthless at all. This is how people look for signals to say, hey, maybe we should do a trial here, maybe we should do a trial there. Now, again, you would hope that the way that these sorts of exploratory things are done in as unfettered a manner as possible to try and point us in the right direction. And it's hard to say that is in fact what happened with these trials, to be honest. And one thing that is absolutely true that a lot of people have said is we probably do need a very good randomized prospective interventional trial.
Absolutely.
Testosterone in appropriately selected men to really have a definitive answer about this, and we don't have that.
Not yet. It's definitely going to happen.
Correct.
Yeah.
And so that sort of brings you on to the FDA warning. Was it really appropriate that the FDA threw out a warning just with this kind of
So the TOM trial, which is the one that's not well publicized with these.
Right. So this was a trial. It was looking at men who were going to be given testosterone replacement to help with muscular strength. And they were looking at what they labeled as cardiovascular events, but their definition was very, very broad of cardiovascular events. So we're talking about things like edema, which is swelling in the legs, fainting, extra beats on the EKG, EKG changes which may look like high blood pressure. So you can appreciate that it is very hard to attribute those kinds of things to testosterone
There's no
therapy.
specific.
Right,
No.
particularly short-term therapy, which is what this trial was. I mean, this was just in a few months, and yet that was all lumped into a group that was called cardiovascular disease incidence, and then it was declared that there was increased incidence. Hey, maybe we shouldn't proceed with the TOM trial. So, again, the devil's in the details here.
So the Fed looks at all this.
Right.
They take about a year and a half to look at it, and they come up with ad hoc meetings. And they come up and they increase. They end up in 2015 putting a boxed increase, almost a black box warning.
Right.
And it basically sent shockwaves through the primary care and men's health world of caring for men as a physician, because men have low T. It's already difficult, more difficult enough diagnosing that, and there is currently, the Endocrine Society has just updated their classified methodology for diagnosing men with low T, which is backing off just on this hardline number and introducing more of who this man is and what he's done and what he's about, his clinical symptoms, mood and libido, and his quality of life. Thank God, this is great news. You're not just, doc, do I have to be 3 points lower? Can we? Should I just take some birth control pills? I mean, I've heard people say this. To give you the number, doc, do you want? I mean, this is because I'm the expert in this stuff. It's, of course, I see it. I look at it. I say, you got to be kidding. What are we doing? So that's a good move. But getting back to the cardiac disease and the etiology of testosterone, they place the warning on it. I mean, it's decimated men. That the primary care doctors really don't want to be involved in it, and why should they? I don't blame them. They're too busy. This is an expertise now. This testosterone management itself, including diagnosis and then managing, is a full daytime. It's a job. And what I tell every man is there's two things that I look at. In the end of the day, if you're going to be on testosterone, which indeed you have to consider you'll be on it forever, because you just don't stop it. Look at the steroid users. Their brains basically deplete, and their endogenous testosterone won't come back after a certain point. This is we know. But beyond that, there's only two things that are going to have to be considered, and that's why I basically micromanage these: cardiac, and you're a man anyway, and prostate. So today's the cardiac day. So when we look at that, there's now in 2018, to wrap up, at least for the research side, we have this Mayo Clinic proceedings. What's your take on their summary?
Well, again, just to give some background, direct-to-consumer marketing of testosterone, I think, led to a huge uptick in awareness that this might be a problem, and people approaching their doctors, and frankly, increased use.
True, that's true. Interesting. Yeah.
And I feel very strongly about this. As with any medication, if you have a responsible and knowledgeable prescriber who is using something appropriately and is following up to see how you're responding, testosterone seems to be a very good idea for men who have low testosterone with symptoms.
Absolutely. That's what we're doing.
And there's very clearly a lot of associations between low testosterone and bad things, metabolic syndrome, type 2 diabetes, muscular health, bone health, sexual health, brain health, mood, the list goes on and on. So there's a lot of associations between having low testosterone and the ill effects for you.
I remember back way years ago, it was just the flip side, like it usually is in our medical world. It was low T leads to coronary disease. Now we got these studies that have they provided us with any support, and are they changing?
Well, Tom, what's fascinating? They've done studies where they've directly injected testosterone into coronary arteries. And the effect of that was actually dilation of the coronary artery, which is a positive effect. So what testosterone has been shown to do directly in the coronary arteries is actually improve the lining of the vessels, which is called the endothelium. It's been shown to improve endothelial function. So they've also done these small exploratory trials in patients with angina. Angina has improved. Small trials. They've looked at people with heart failure, and their walking distance and symptoms have shown improvement. So we have data that there is some direct beneficial effect of testosterone. Direct effect.
With men with coronary disease.
Correct. They've also done these studies. Now this gets a little technical, but a coronary CTA. This is a high energy CT scan. You can get very detailed images of the coronary arteries and the plaque or the buildup in those arteries. And what you can actually do on a good quality coronary CTA is you can actually tell the constituents of that plaque. So, broadly speaking, you have a soft core. That's not the good part. That's the part if it ruptures, forms a blood clot. That's a bad thing. That's what causes a heart attack. And you have a cap over the top, which is called the fibrous cap. You can imagine if that is thick, it's sort of like a callus. It's much more stable. It's not going anywhere. If that's thin, it's much more likely to rupture. So they actually have CTA studies where they've shown that overall the plaque gets bigger on testosterone, which you think, ooh, that doesn't sound good. But what's actually getting bigger is that fibrous cap. It's getting thicker.
Incredible.
So again, we have a lot of actually, not conclusive but tantalizing data that there's benefit there. And again, coming back to what I was saying about a responsible prescriber, I think with direct-to-consumer marketing, maybe a lot of people will put on this therapy that maybe didn't need it.
True, we know it's true.
Right, because maybe people were prescribing it who weren't really knowledgeable.
What man doesn't want to wake up and feel better and lose this belly and have more sex?
Right.
So,
You're absolutely right. But the thing is, sometimes those symptoms are not from the T. Right?
Absolutely.
So this is the thing. Men hoping for a magic elixir.
No.
But you're diabetic and you don't exercise and you smoke and your sleep quality is poor and your diet is poor. Testosterone is not the answer there, right?
True. It's a multifactorial piece.
But on the flip side, if you have someone that is taking care of those issues, their testosterone is low.
Absolutely.
And they do feel lousy and their mood is poor and their sexual health is poor. And now you measure that, hey, it is low.
Well, this is what I do as a metabolic doc, where it's metabolism, blood pressure, cholesterol, diabetes, sugar, all the pre-states, and then with men that have low T. And it's just incredible. But it's the amount of vigilance that I focus on is mainly is incredible. It's on the cardiac. So let's talk about this. So my modern world, my current world is that there may be men have heart disease before women. We're just more at risk. I always tell that. It's just true. And then when you get older, we say that's the box with the 40. You're 40 and now you're a man. That's a check box. This is framing here, right? We've done videos before. Then the next box is you're 40. Wow, right there you should be on statins and all this. Another video. So, well, you're at risk for coronary disease. Well, we look at your cholesterol. We look at your HDL, LDL. We look at your lipid. We look at your glucose, blood pressure, BMI, smoking status, activity, family history. That's about it. When you look at all these things, men are naturally at risk anyway. When they have low T, you replace the testosterone. So I check all those boxes, and then I look at them and I say, I want to live to 110, me. So what can we do for all men, and not even just on testosterone, but for my men on testosterone, I do a frontal attack, if you will, on the coronary disease risk factors. Am I right? Because, testosterone does lower HDL for almost all men. It doesn't necessarily, and the data supports this. All these, and then this is some randomized perspective. This is 20 years of data. Small trials, large trials, not for end outcomes of death, but as far as what it does to the lipid profile. It lowers HDL, but it can actually lower LDL. That's kind of independent of who the man is, what he's doing himself, his genetics and his eating, his training, his behavior. Other aspects are it increases red blood cells a bit. Not every man is polycythemic, but most men, definitely all of them, go up. Does that lead to a hypercoagulable state? Blood pressure. So we're hitting all these basic tenets. If you're on testosterone, you get some edema, and they talk about that. It could be a little bit of just lower ankle edema. Is it pathologic edema? Is it intravascular edema, which you and I know as hypertension? Can you imagine? So blood pressure, cholesterol abnormalities, it does affect it. Even testosterone, not to mention steroid use. It does affect it. What I do is I stay up ahead of those factors. And we use evidence-based medicine. And I'm not treating men that are not hypertensive, but if they're up to the level of 130, now 130 is hypertensive. That's hypertensive now. So I'm hitting these early with protective medicines, of course, in addition to the diet and exercise, plant-based diets and all these things. But you see, that's what I see to be the now and the future for men on testosterone, to protect them, stay ahead of that curve. If they're going to have a coronary event, because they're just men anyway, not to mention women can too, but men have it earlier. How would you tweak what I'm doing?
Well, I think the main thrust there is that you're paying attention to those factors, both before and during testosterone therapy, appropriately selecting the men for testosterone therapy. So again, you're not taking someone with normal levels and aiming for super physiological levels. You're trying to identify those with truly low numbers and again associated symptoms, and trying to tease out whether those symptoms are in fact from the low T or something else, and then following up on what we know are potentially sequelae of that testosterone therapy. And if they're, for example, the hematocrit level is a great example.
Incredible.
If you slap someone on testosterone because they're tired and you don't know their numbers and you never follow up, that would strike me as the kind of guy that's at risk of developing very, very high red blood cell.
Which happened in the initial those years of the direct consumer marketing. Unfortunately, it happened, and guys come into me from anti-aging. Everyone knows I'm not an anti-aging doctor, and I'm unhappy with anti-aging doctors because it's unethical to me. Anti-aging, try not having a heart attack. My form of anti-aging is not having a heart attack. Call me crazy. So when you look at these multifactorial approach on it, and all these men come in, so many men come in with horrible lipid panels, not to mention they're pre-diabetic, if not frankly diabetic, not to mention some of the PSAs are elevated. They actually have prostate cancer. No one really diagnosed that. And then, but they're all red cells are up. They have obstructive sleep apnea. It's a mess, and it's a lot of work. So, but it's coronary. So it's not, you focus everything in the end. You're doing this for one reason. Why I feel so great, frankly, is I have a frontal attack on the coronary risks. And even using metformin, and if you have a little LVH or ramipril approach, I mean, it's brilliant. And there's can we do a study on this population if you're on T and we're using ramipril, metformin, and we're using, the statins versus another group? Could you imagine how phenomenal that would be?
Well, I mean, I think, again, I think it comes down to, it's important to be aware that there actually are very few randomized prospective trials, certainly none that are large looking at testosterone replacement and actual cardiovascular outcomes. I mean, that's certainly one thing to be said. You were mentioning some other issues about, potential concerns about testosterone therapy. There are some people that are of the opinion, and this has to do with platelets potentially getting activated, although this has been shown in sort of lab studies, not really in people, that you can activate the platelets, and what that means is those platelets may be more likely to clump together, which can be the start of a clot.
Hypercoagulable state,
but it's not clear what the significance of that is. Again, that we need the trials. But some people say, hey, if you've just had an acute heart attack or you've just had an acute stroke, maybe you want to wait somewhere in the order of 6 months before you initiate testosterone therapy. And that's sort of a cautious statement.
Makes sense.
Based on theoretical risk. And I think that is a reasonable statement to make, and it's a reasonable concern. But again, you don't want to over-extrapolate that general recommendation, which is actually not based on data. It's based on theoretical effect. So you don't want to extrapolate that now to denying people that really have low T and symptoms that therapy because of inappropriate concerns.
And that is the conclusion. This is for a video for everyone, men in the world, of course, anyone who loves a man who may have signs and symptoms of low T, and physicians. This is why I bring this physician in. That's why we have the data right there, because really we get respect only when you properly evaluate the data, because when you're an evidence-based doctor, which you really have to be this day and age, not just winging it, but there is a paucity, and there is certainly, in this case, with this study of testosterone and coronary disease, what looked back years ago, 3 or 4 years ago, I was myself going, oh boy, here we go. I better anchor these guys down really tight, and I actually still do. With or without testosterone, you do it because it's just the nature of what's going to happen to all of us. So in America, but it's just amazing that it turns out to be the data, and Mayo's backed off on it. I know the other experts in the world have just really criticized.
Endocrinologists,
they're backing off, so they should really repeal this warning on testosterone. That's it. And I want to thank Dr. Nowlan for coming in today.
This was great.
And please always see your physicians and stay on top of my media and social media. And just stay well informed, and always reach out to a very good physician. Feel free to show this video to your physician. And we're trying to spread the word on men's health and replacement androgen therapy and cardiac disease prevention. Thank you so much. Thomas O'Connor here. I'm glad you made it to the end of the video. If you liked it, hit the like button and please subscribe to our channel. And I look forward to bringing you more cool and interesting videos just like this in the future. Stay strong and healthy.